Good morning, everyone. So I usually like to start all my talks with a joke or something funny, a funny anecdote, but I come from the country with a completely dysfunctional government that just started itself again today. And there's a lot of humor in that, so maybe I'll let that stand for my humor. It's an unfortunate situation, but as of today, you can again visit the Statue of Liberty if that's what you wanted to do, and the national monuments, so we're all pretty happy about that. My talk today, what I've tried to do is integrate several different fields because I understood there'd be different types of people here today. I'm going to try to talk a little bit about research, a little bit about the particular program, the Family Critical Time Intervention, and also I'm going to talk a little more policy, philosophy-wise about homelessness and homeless families. It's very much on the forefront of my mind these days. One of the areas that I do a lot of advisory and consulting work with is in New York City, where we probably have, the most entrenched homeless problem. On any given night, there are about 50,000 people in shelter, another couple thousand on the streets, and then probably just as many who are couch surfing and doubled up, if not more, and precariously housed. So it's quite an interesting problem. There are very few services available in the city these days, in particular for homeless families, but we'll get to that soon. So I am going to talk about the original critical time intervention model so you can get an idea of where we started. I'll describe the family adaptation philosophy and also the research, a little bit about how the model works. I'm going to talk about a systems approach to rehousing families and how this model fits into that scheme, and then some other uses of CTI that I've been involved with. Also, from what I do know about your system, I will try to interlace some information and comments from my perspective and the perspective of using this model within a system like yours. Now, the critical time intervention was first developed because there was a group of clinicians working with homeless single men in New York City at a very large shelter. And they realized that these men were involved in multiple systems, going in and out of homelessness, hospitals, jail, street, shelter, what was coined by Kim Hopper, one of my colleagues, as the institutional circuit. And these clinicians wanted to try to find a way to stop this cycle from happening. So there also were finding that people would transition back to homelessness from housing, into and out of housing. They would become homeless from hospitals, between residential treatment programs and home, from prison to community, from foster care to independence. And so one of their questions was, since people are winding up homeless as they make these transitions, is there a critical time during which this happens? Is there time during which it's the highest likelihood that you'll become homeless? The interesting thing is, while this group of clinicians and researchers were developing this model, a group that I work with at the Nathan Klein Institute was actually examining data on about 2,500 people who were homeless and moved into housing to try to determine where that critical time point was. So it's interesting because we were working on the same problem in the same way. It was about 3,000 people. And what this shows is for about 3,000 people who moved from homelessness to housing at this time, what their survival rate was. And then we calculated where the curve was the highest and where the likelihood of falling out of housing was the highest. And what we found was essentially that if you provided some transitional services that was very intensive for the first 3 months and went on for some period of time, up to say 9 months to a year, you could probably capture the vast majority of people who fall out of housing who had originally been homeless. So while we were doing this analysis, they had already started the CTI model, which is a 9-month model. So it's very interesting that this was sort of all going on at the same time. If you stay in housing, you have survived. This is a survival analysis. If you fall out of housing to homelessness, you haven't survived, right? So the question is, who stays in housing? Now, this is a picture of the shelter. Have any of you seen this before? It no longer exists, but this shelter had 1,000 beds in one room. And it existed for actually quite some time. If you're familiar with New York City, it was across the street from the Columbia Presbyterian Hospital on 168th Street in an old armory. And it was a really dangerous, difficult place, but for some reason, people would leave here and move into housing and come back. for various types of reasons, and the clinicians were very concerned that they would spend all this time working with folks to move into housing, and then they wound up back here again. That's how the critical time intervention model was born. It's a transitional model. It's designed to help people transition from one state to another. And why don't people, quote, survive? By here surviving, we mean stay in housing. One thing is that we have a need for supportive relationships, and sometimes when we move, we lose those. We have a fragmented, siloed service system. I think you have somewhat of the same, where everything isn't sort of integrated. So as you move from one system to another, you can lose all of your ties. There's a lack of continuity of care. There's no one sort of helping you as you move from one place to another. But when you do move, you have your family and friends to help you. And often people who are homeless have no one to help them. So there's no continuity. And the results, as we all too often know, is recidivism to homelessness, prison, hospitals, and substance abuse. And right now I'm really talking about the original population that this model was developed for, and that's homeless single adults. What does the critical time intervention look like? First of all, it's a time-limited intervention. It calls for a 9-month time period. It's a case management model that's highly prescribed and highly scripted and has a lot of information about how you would do case management. The 9 months are titrated. That means that it starts very intensive and it gets less so over time. Specifically divided into 3 stages. It calls for a focused team approach with the aim of reducing recurrent homelessness. This was the major aim of the original model, was to try to reduce people coming back to homelessness. It provides a continuity of care because these case management teams start working with the individuals while they're homeless and continue to work with them as they move into the community. Again, it starts before the transition takes place. The practices employed in the original model are motivational interviewing and harm reduction. This was early on in both of these areas. Motivational interviewing up to that time had mostly been used just for substance abuse, and in this model it's used with whoever you come in contact with, and it was also from the very beginning a harm reduction model. The clinical interventions for the single adults are mental health treatment compliance, substance abuse, money management, prevention of housing-related crisis. This is very important because one of the things they found is that a lot of these individuals would move into housing and not know how to do things in their new housing and cause a disturbance. And then the people who ran the housing or the landlord would get very upset, and neighbors would get upset, and then the person would be sort of sought after for eviction. And what the CTI model does is it has someone that can be called to come in and help intervene and negotiate those situations. So it reduces the likelihood that a internal housing crisis would result in eviction or homelessness. Family psychoeducation also plays a part because many people who are homeless are disconnected from family who they could have a relationship with. And then also at some later point, as someone gets used to their new housing, there's a skills training component. The 3 stages of the critical time intervention, which we maintain through every adaptation of the model that I use, are transition, which is the time period during which someone is actually making the transition from one state to another, be it prison to community or shelter to housing. The tryout phase, which is where you've tried to help connect someone to community services and programs and work or whatever it is, or school, and now you're trying to see how it's working and you're trying out all these new connections. And then the transfer of care phase. This model very, very purposefully ends. And most of the training programs about the model tell case managers you need to start talking about the fact that it ends on the very first day. It purposefully ends because the goal is to transition someone with a soft handoff into community services or whatever other programs they may or may not need. It is not intended to be a long-term program like an ACT team. It's not the intention. It's a very flexible model. It was designed to meet an individual's needs. So the model does not prescribe which of the interventions or programs or services you need to work on with someone. It does require that you find one very specific issue or reason that you believe and the individual or family you're working with believes is the reason that they were homeless in the first place, and that be the main focus of the intervention. Not that you don't work on other things, but you need to have a main focus. Because the goal of this model is to have people stay housed. You could have a lot of other goals, but that's the main goal. You can provide services with this model in a direct and assertive mode, and or be maximizing linkages to the community all the time. And the services, the way the model is set up, the goal is to increase autonomy and recovery. Now I'm going to switch gears a little bit and tell you something about the family critical time intervention model. This is sort of the philosophy that the model is built on. First of all, we do recommend an organization uses this model that they do continue to provide a comprehensive assessment, even though we are going to emphasize that they concentrate very much so on one specific issue. It's very important to have a comprehensive idea of what's going on with the family, both the parents and the children. Also, you're going to notice while I'm talking, I'm very often going to refer to the parents as the mom, because we know that the largest percentage of homeless families have a single mother. So dads out there, I apologize in advance. We do also realize that homeless families come with lots of issues. They could have a child with a serious emotional disturbance. The mom may have a substance abuse problem. One of the kids may have a disability. The mom may have a long history of domestic violence. But we very strongly believe that the underlying reason for their homelessness has to do with a lack of affordable housing. I've looked at this in many different ways, including the fact that in places that have a very high vacancy rate for housing that look like other cities have very low rates of homeless families. In other words, if it's easier to find housing and you have a housing market where you can pay a reasonable amount for housing, even if your family has problems, you are much less likely to become homeless. So if you have a housing market like in Ottawa, I think you said you have a 1% vacancy rate, and we have a almost non-existent vacancy rate in New York City, it becomes easier to become homeless. I bring this up because when you're thinking philosophically about these issues, it's a very good idea to understand in your community what it takes to become homeless. If you have a very small vacancy rate, it's very easy to become homeless with few problems. If you have a high vacancy rate and rents are not as expensive, you won't become homeless unless you have some pretty severe problems. And I'd like to keep this in perspective because homeless families and from community to community, this is a very heterogeneous population. And I believe that the solutions have to vary from community to community based on who it is that becomes homeless in your community. So I don't see a one-size-fits-all solution across communities. When I go to a community like one in Minnesota where I've done work and apartments are pretty cheap and there's actually a fair amount of sort of good, low to middle, low wage jobs, their homeless families, really a high percentage of them have some serious psychiatric and substance abuse, other kinds of problems, like really serious, but a high percentage of them, because you can have low levels of those problems or moderate levels of those problems and stay housed. The landlord's less likely to throw you out because some rent's better than none, right? So these things are important to note. And that's some of the underlying philosophy of our model. I also believe very strongly that psychosocial roles play a big part in why families become homeless. Even the very early studies in the late 1980s and early 90s, which compared very poor families who became homeless and very poor families who did not, one of the only predictors had to do with there being some type of event that happened for the family, and the mom didn't have anyone she could rely on, didn't have someone who could lend her $300, or the relationship that she was in went awry, or someone came back into the relationship with the family who was destructive. So these are all sort of more social types of problems. That is very often the case as we see the difference between very poor families and homeless families. That these other issues, there are more stably housed families with moms who have substance abuse problems than there are homeless families or homeless families that have substance abuse problems. So something else happens. Now, I'm making this assumption based on lots and lots of data from the US. So you could make the case that it's not like that here. I've done a little bit of work here. I've been here a few times and talked to people. I've read some literature. I don't think it's different, but you could make that case. You'd have to argue with me a long time to make it. Because I can also tell you that I've just recently come back from the Netherlands, where in fact, what I just explained is the case. I also visited folks in Denmark, where they have hugely supportive social system. They have the same kinds of problems there. I've spoken to other researchers in Sweden, same kinds of problems there. These are sort of universal issues, and it might be different here, but I would seriously doubt it. And I'm probably not telling a lot of you things you don't know. I just may be putting them together in a different way. John did mention, and I will mention again, that the critical time intervention for families has been noted as a model program by the President's Commission on Mental Health. In the US, this gets a big wow, okay? But here, I don't think it means a lot, right? So the research on CTI for critical time intervention, or CTI for homeless families, for those of you who are here as students or researchers or work at the university or have an interest in this, and I'm sure your professors will tell you, these are very complicated studies to put together. We did a large randomized trial with homeless families. It's one of the only ones that's been done in the US. And part of the complication, in our case anyway, is that you need many different types of funding. My guess is you would here also. We had funding from a federal organization called SAMHSA that provided funding for our parent study, so that was to follow the moms over time. We had funding from the National Institute of Mental Health to do a children's study. I always emphasize the children when we talk about these studies. We had funding for the intervention program from the state of New York, which is where we did the trial. And we had funding from two sources for the housing. One was the federal agency HUD, which does housing and urban development, and from the county where we were doing the work. It took me 2 years to put this together, and one of these started a little late, but it was quite a feat. It's probably not one I will ever do again. I'd be happy to help other people do it. These startups are very complicated and difficult. You have to get every organization on board, and then all of these have to start and end at the same time. So it's sort of a trick. Fortunately, I have an MBA, so I have other ways of planning and figuring out how to do this and play with the money. So I think that's a benefit. If you want to do this kind of research, hire an MBA. That's my advice. There were many different parts to the study. We did a family CTI model fidelity study where we compared our model to the original. This was a qualitative study where we did a lot of focus groups and interviews. And we actually did completed a family critical time intervention manual, which was quite lengthy, and we've recently pared it down with some federal funding. We did a family composition study. There was an anthropologist attached to this study, to the overall study, and she was looking at family composition. So that's changes in how families work. I'm sure you have the same thing here, especially with homeless families. Children come and go. Children are removed. Children come back. Children go to visit a relative somewhere, sometimes while the family's homeless, and then they come back. In some cases, a family doesn't want to bring an infant into shelter, so they'll find a relative to take the infant. In some cases, it's a teenager they don't want to bring to shelter, and then they come back. And so there are all these different ways that families change over time, and she did an ethnographic study. And one of my colleagues, Beth Weitzman, early on actually termed this coming and going, and particularly the government removing children, as family dismemberment. It's not a pretty term, but it sort of makes sense. So we did a study of that. We did a study of the children in the families. We had a triangulated study. We interviewed the children about themselves after a certain age. I think it was after age 6. We interviewed and had teacher reports, and we also interviewed the parents about the children. So we had a triangulated study. My colleague on this was Mary Beth Shin, who's now at Vanderbilt. That was one of the first, it may still be actually the only study randomized homeless children from one intervention to service as usual. And that followed many children, and we also did a neighborhood study. So we wanted to see whether a neighborhood where families wound up had an impact on these children. We also, at the same time, ran another program because our original funding required that the moms be of a certain age. They had to be, I think, 23 or older, and they had to have at least one child with them over the age of 1. And we found a lot of younger families, younger moms, who we thought qualified for our study, but we couldn't take them because of those requirements. Now, some of the criteria to get into this study, the moms had to, we gave them a test to see if they had any current mental health or substance abuse problems. They had to have one in order to get into this study. They had to be considered by the shelter system where we were working to be a family who was likely to stay long-term, a multiple problem family, and one who probably would not move into housing soon. We had decided that we wanted to look at families who were considered at the bottom of the pile, at the bottom of the list. So we ran this Young Mothers program simultaneously to the big study. We only had funding to do an evaluation, but I'm going to show you some of the results in a minute. For our randomized trial, we had the critical time intervention versus the system as usual. We conducted interviews at baseline. So that was within 2 weeks of when someone entered shelter. 3 months, 9 months, 15 months, and we had a 24-month follow-up, particularly for the children. The target was homeless families, single moms, as I said, with mental illness and or substance abuse problem. One of the main things, and the reason that I wanted to do this study, was because many service systems in the US, and this one also at the time, were growing, and they were getting clogged up. They were getting clogged up with families who were staying longer and longer in shelter. And what we were told when we went and did some sort of preliminary work was that these were the families who had multiple problems. And the shelter was not going to recommend them for any type of housing subsidy, housing voucher, or housing program until they cleaned up their problems. So they ran what was called a housing readiness system. If you were housing ready, if you could get that box checked on your form, you would be put on some type of list to move into housing. If you were not considered housing ready, you would stay in shelter. So I came in and I said, you know, if you wanted to unclog your system, here's what you would do. You would give the people who are most likely to stay the longest housing first. Because a lot of the other people that you have here, they move out on their own. A lot of people just move in and out of shelter, and they don't need that much help. So if we give the people who are most likely to stay a long time a little extra help and move them out quickly, in other words, rapid rehousing, I wonder what would happen. Wouldn't it unclog your system? It took me several years, of course, to convince the system that we wanted to try this. People were very entrenched with their ideas and notions of how it should work and would work. But it wasn't that hard to convince them because we did a bunch of focus groups with shelter staff. And we would ask them, what is the housing readiness criteria? How does someone get that box checked? And I would hear things like, well, they have to go to all their programs and services, and once they start doing that on a regular basis, we feel confident we can check the box. And I would say, but did you measure if they're actually improving? Well, they weren't that sophisticated, so they didn't. They just measured whether or not someone came. Okay, so that was some people. Other people told me things like, you know, I had this mom who came every day to my office and begged me to check that box. And she was so obnoxious. She bothered me so much that eventually one day I just said, here, and I checked the box. And I heard that story over and over. I started realizing, you know, it's great housing readiness criteria, right? If you can be persistent, you're ready for housing. I said, okay, persistence, that's a really good trait. I like that one. I don't know about the other ones, but that one made sense to me. So it was really sort of a fluid kind of system. Even though they were doing evaluations and assessments, the other interesting thing about the system was they did a 2-week-long assessment of families, and they collected a lot of information about them in shelter. But as soon as the family moved to another shelter or out into the community and was working with other service providers, no one got to see that assessment ever. Almost every system I've ever visited has something like this. I know in Canada you have the OCAN assessment, and it can follow you so other people can see it. That's an anomaly, I'll tell you. It doesn't happen many places. But it's important to share all this information, right? Because if you're going to spend all that time collecting it, other people will want to know who work with these families. So yes, we did have a very early version of rapid rehousing. This was before anything was coined or termed as rapid rehousing. We just said we were going to move them out fast, out of shelter. And we also used scatter site housing. And at the time, this was when the permanent supportive housing for families movement was starting. It was built off of the permanent supportive housing movement for single adults. It had no evidence. It still doesn't have much. They were moving families into it who were homeless, saying that there was a need for it. I'm not sure how much need there is for it. Now you're getting my opinion, but I don't see any evidence. In fact, I'm working with one location in the US, in the Midwest, to help them move families out of permanent supportive housing by using family critical time intervention to move them to more independent housing. So there you have that. Our target population for our research study was, like I said, the families had to have active mental health and substance abuse problems. They had to have some other problems too. But when you look across the data from our pilot before we actually started this study, you could see that the population in the shelter, less than half of them had a high school diploma. They all had very poor work histories. There was a lot of divorce. A lot of the moms had never been married. There was a lot of substance abuse. There was a lot of domestic violence in their past. This wasn't specifically a domestic violence shelter where we were working. However, the system was so clogged that a lot of families with domestic violence were coming there anyway. About half of the families had never been homeless before. A third had been homeless one time prior, and that could have been in childhood. This was the mom's report. And about a fifth had been homeless 2 or more times prior to their current homeless episode. This is what the study looked like for those researchers out there. You can see families would arrive at the Department of Social Services and go to an assessment center, which was a family shelter, where we would do our intake and random assignment. We first screened all the families that were sent to us to make sure they qualified for the study, asked them if they wanted to participate, and then we did a random assignment of the families. And then after that, we would do our first set of baseline interviews. So the control group had a shelter assignment and went through the service as usual and stayed as long as the system wanted them to stay in shelter. The families who went into the critical time intervention, shortly after they entered the study, we were able to move them into an apartment, so they had much shorter shelter stays on purpose. And then other families from the control group who were in the shelter system, they also had the opportunity to move into housing over time. I can tell you that this design was a bit problematic when we started because it's a combination of CTI and housing versus housing only or shelter. It's not quite right. But about halfway through our study, this county got an extra amount of housing vouchers to use. And they were so happy that we had been taking families with a lot of problems and moving them out of the shelter system that they gave a whole bunch of housing vouchers to our control group. So we were sort of not so happy at the time, but then we decided we were really happy, right? Because now we had more of a pure comparison of critical time intervention versus not. So it was a very strange time for us, but we were very happy. Regardless, we were happy that people got housing vouchers. That was a good thing. Okay, for those researchers out there, again, this is the different areas we covered in our research interviews. It was a lot of different topics that we asked about. It's pretty typical. I don't know what happened to and this is what the children's interviews looked like. We again covered a lot of different topics with the children. And as I said before, we interviewed the moms about the kids, we interviewed the kids, and we had teacher reports as well. You're getting the feeling this is a complicated study? It was really complicated. I'll tell you about another layer of complication is that I decided in my infinite wisdom that for interviewers for this study, we would hire mostly formerly homeless moms to be the interviewers. And of course, at my research institute, the first thing I started getting were phone calls from HR saying, "Did you know this person has a criminal background?" Yes, I knew that. "You can't hire them." "Yes, I can." Of course, I had written that into my grant that I was going to do this, and they signed it, so they had no choice. But it was pretty complicated, and as you can imagine, I hired a clinical social worker as the supervisor for the interview team. But if you can do something like that, it's great. It's a great way to involve consumers. Participation and attrition in the study, we did pretty well. I think we had a pretty good retention rate over time. Things got pretty bad at the 24-month point, but I think we sort of expected that. We ran out of money. We had other issues to follow people. And as some of you are finding out now, homeless families are pretty mobile. So they can be difficult to retain. I think we did pretty well. The study results, the family critical time intervention families had less time homeless. That's just discounting the fact that some of the people in the control group didn't have access. So even with that, our families did better. And there are fewer returns to shelter, which was something the shelter system was interested in. Both groups had significant reduction in mental health problems. The GSI is a measure of mental health. And what I want to show you here is something very, very interesting, and that is that for both of our groups, regardless of an intervention or whether or not this looks like this, whether or not they got any mental health services over time, that many of the families started off in the study in a clinical range, which we knew because we recruited them that way. in almost every mom, by the time we were 15 months into the study, her mental health was in the normal range. It's a very curious thing. And I'm actually not the only one to have found this, but it turns out being homeless and going to shelter is a traumatic event. And if you measure someone's mental health status at that time or near the time that they became homeless, guess what? They don't look so good. If you wait and measure it, they look a lot better, pretty much no matter who they are. Isn't that interesting? You're saying, oh, I could have told you that. Maybe you could have, but I think it's interesting to see this because so many shelters measure mental health on the way in or while they're in shelter. And you're not going to see good things. But if you wait, if you're patient, you will see a lot of it subsides. That was a very important point I'll come back to later. It's very important to know that that's what these families look like over time. It's so interesting, right? That this is what happens. And believe me, especially in the control group, people didn't get any service. Because we measured, do you think you need service? Did you get service? We had a lot of these questions we answered over and over and over again. So we knew who was getting what. Okay. The children's study outcomes, we have a paper that's coming out soon. We show that there are better school outcomes for the children in the family critical time intervention and better mental health incomes, both internalizing and externalizing at different age groups. So we've considered that to be a success. Our best outcomes are for the kids. I can't emphasize that enough. If you are involved in programs or planning programs or running programs or you're a policy person, and you're looking at things having to do with homeless families, measure something about the kids. Because what you really want to know is how are the kids doing. And if you have nothing else you can measure, find out if they go to school. School attendance can be a proxy for many, many things about a family, homeless or not. If the kids go to school every day, something's happening that's going right in the home. If the kids don't go to school every day or it's sporadic or they have huge gaps in school, something's not right. So I would say if you have the opportunity to do that in program or evaluation design, I would measure the kids. You don't have to do it extensively like we did, but it's important. Back to the stages. Again, I mentioned what the stages were before for CTI. This is sort of a diagram we use to show that CTI, the phases, they taper off over time. The features of the model are that it strengthens ties to services, family, and friends. I always emphasize a soft handoff because we're not just dropping the families at the end of 9 months. We hope they've connected to services they need. It provides emotional and practical support. The time-limited piece is great. We've heard from a lot of practitioners, clinicians, and case managers that they actually like it because it used to be a lot of case management models went on forever, and you didn't know what you were accomplishing, and it could just drag on. And this gives both the family and their caseworkers the ability to actually plan for a goal and see it to the end. This is our young families evaluation that we did. We had moms and pregnant women from 18 to 25 years old. They were all literally homeless at shelter. During the evaluation, we had 50 families, and we did structured interviews at 3 months, entry 3 months and 9 months, and semi-structured interviews with all staff at 3 points in time. This program was structured a little differently because obviously we had an emphasis on different things. This is what the population looked like. It really reflected the general homeless population of families at the time. There were a lot of little tiny kids and pregnant moms. But by 9 months, we had found that there was an increase of 150% on average for their income. That could have been benefit-based, but still, they were accessing income. There was an educational increase that was significant. All but one family had health insurance and food stamps, which is our way of providing food assistance to poor families. And 83% were still in housing at 9 months. 15% of those were living with family and relatives, and we highly emphasized in this model returning to family because they had a CTI worker to help them work out the problems. This is a model that's being used in a number of places and was picked up by a couple big foundations in the US to disseminate it around the country. A lot of places, they're very concerned about the young families. And since they face a number of different types of challenges because they don't have life experience, this model can be very pertinent and effective with them. But the emphasis is a little bit different because the emphasis is more on learning how to be a good mom, baby care. We were able to have someone attached to the study who was a pediatrician, child psychiatrist, to work with the moms and really teach them about well care for their babies and, just how to learn how to be a mom. And that was great. These were the high priority issues for that program. Pregnancy prevention was very big on this one, and there were no additional pregnancies even at the 1-year follow-up point with these young moms. So we were very proud of that. And of course, we worked very hard on risky behaviors and relationships, trying to help them understand how that affected their children. So now I'm going to go a little bit philosophical, take a few minutes. So I have an evolving philosophy about homeless families, part of it because I started up my work in homelessness with homeless single adults and not really realizing all the huge differences between single adults and families by the time I moved into families. I still do some work with single adults. One of the things that has always intrigued me that my friend the anthropologist started uncovering in New York many years ago was that like 60 to 70% of the homeless single adult women in shelter are actually moms. They're separated from their children. We have this situation in many places where if you have a serious mental illness or a serious substance abuse problem, you could find yourself someday in a single adult shelter as a mom, having lost your kids, having had them taken away over time. It's very complicated. I don't know about in your system, but in systems in the US, you generally try to help a person in a single shelter find housing for a single person, which means it makes it even harder to get your children back. And we're continually looking at those issues and how to think about that, because those are other families. But what makes homeless families different from families who don't become homeless, who are poor, from the same neighborhood, from the same building? It's a very interesting question to me. There have been some studies that actually looked at this. They usually come up with the same answers. One is that they're more likely to become homeless if they have an additional child. It puts a lot of stress financially and otherwise on a family. The apartment could be too small. They could get asked to leave if they were living already with another relative or a friend already with some children. Now another one is too much. They wind up being homeless. There are very few known predictors, however, of how someone becomes homeless from being poor. So is it going to be you or your neighbor, is sort of the question. We actually don't know a lot about that. And it remains so today. It's a very heterogeneous group. We also have a very difficult time figuring out who's going to be homeless longer or shorter. Some of that, I maintain that a great deal of that is based on the system and the housing vacancy rate in the area. If you have a system that doesn't actually sort of help people with lots of problems move out fast, they will stay longer. If you have a system where there's no subsidy, there's no public housing, there's not much you can do, your lengths of stay will be longer in general than other places. A lot of these things are very system affected. So you have to sort of tease that out before you can determine why are some families homeless longer than others. But we don't really know the answer to that. I've also been very much in the camp recently of a theory called progressive engagement. Dennis Culhane, a good friend and colleague of mine, wrote a very interesting paper about how to use progressive engagement with homeless families. And it sort of is part of the underpinning of the rapid rehousing system that we developed in the US and funding, and I know you're doing some rapid rehousing here. And the theory goes like this. You give people what they need until they're okay, and if it's not working, you give them some more and some more. It doesn't necessarily mean you give them more money. Maybe you give them more service. But the progressive engagement part means that you don't give everybody a lot to begin with, because that's not a great use of your resources, and a lot of people, are going to be unhappy with that. But if you start with some small amount and you build over time for those who need it, you may be better off. But if you start with a small benefit for everyone, I don't know what the return to shelter rates are like here in Ottawa, but in New York City, where we have a terribly low vacancy rate, it's very hard to find housing. We have no public housing available to homeless families. It's a 30-year waiting list. We have no subsidies, okay, nothing. And we have families who leave shelter and don't come back. As a matter of fact, most of them leave and don't come back. So The return rate doesn't dictate that everyone needs something from our public pocket. I'm a pretty liberal person, but I get this point, you know. So the question is, how can we maybe give everybody some small amount and see how they do over time? And maybe it's not money. Maybe it's like some kind of cafe benefit kind of package where you say, oh, you have a job, but your real problem is to keep that job and move up in that place, you need childcare. You can use your benefit for childcare. Oh, you have a low-level job, but you need some training to do better over time. You can use your benefit for training, right? Something like that, so you can sort of start people off, get them back out there. That's the kind of benefit. You know, there's always this question, if you give some kind of benefit, more people will come in because they'll want the benefit, right? That people want to become homeless so they can get these benefits. This, for the past 12 years, has been the issue in New York City, that the government has been afraid to give anything because they're afraid of what they call the draw to shelter, which we don't even know how big it is. And when I talk to families, they're not clamoring to come to the shelter to get anything. They really don't want to lose their housing. In fact, we know that people will do just about anything to keep their housing. So, in any case, this is not an expensive proposition to give everyone a small benefit to help them on their way. You will have some return to shelter. It will be small. If you have a return to shelter with progressive engagement, then you want to give them something else. I say give them a short-term intervention like CTI. Try that. The next time they leave shelter, attach someone to them for 9 months and help them. So maybe transition's hard for this family. Maybe they weren't actually able to use their benefit correctly or well or figure out how to do it for themselves. Let's see how they do for 9 months. Let's save our most expensive resource, which is permanent supportive housing, for the families who still can't make it at the end. That's one idea of a system that has progressive engagement. So I'm going to turn for a minute to your shelter system and your housing system here in Ottawa. And you can raise your hand and tell me I'm completely wrong about this. My understanding is that you have some shelters for families, and then you have some motel rooms that you use, right? And the motel rooms have a lower level of service than the shelters. And if you're in a motel, there's a chance when a shelter room opens up, you could move there to get the service. If I were you, I'd flip it around. I would design the system from the knowledge base that I have. I would say, move the families first into the shelter, and as a family starts to sort of get themselves together, since they still have to wait for housing, then move them to less service, move them to the motel. These are the sort of ideas I think we have to start thinking about. What resources do we have as a community, and how can we best use them to help families move back to independence? Now, I would say, of course, this sort of turns your hotel, motels, rooms into transitional housing. I'm not a big fan of transitional housing because in systems where you want to turn transitional housing into housing because it doesn't really serve much of a purpose. But in the case where you have to wait a long time for housing, if you have a limited amount of space in a shelter, but you also have these sort of more independent units, which are motel rooms, I would think the logical thing is to sort of do it the other way. This is what I do. I go around and I look at these things and I say, this is backwards, right? It's like the homeless system that we went into that was keeping the families with the most problems the longest. And it was clogging up their system and they had to keep building shelters and they didn't understand why. And I said, well, if we take all the people out first that probably won't get out on their own or get out soon, you'll relieve the congestion. And in fact, 2 years later, they started closing shelters. They didn't need them. So there are other ways to think about how your system works and how best to organize it so it works best for the resources you have and for the families. Because, right, our goal is to get rid of homelessness, especially for an individual family, right? That's the goal. So if we can help them transition to it and step them down, that may be a better scenario for them. I have the benefit of not having to work here. Right? And I sometimes can see the view from the airplane, because I'm not working in the service systems. But there are some things you could think about to make things maybe a little more workable. And most systems could. I'm not just critiquing yours. I was just in some other countries, and as I travel around, and believe me, I hand it to New York City all the time. Their system is really nuts. Anyway, and that would actually be a little bit more Yeah, so that sort of follows along the tenets and the philosophy that I think is becoming more prevailing, that we need to help create more autonomy and step down our services to see what's the lowest level we can get away with, and families will survive. They will. Believe me, they will. Which brings me to my last topic that I want to talk about just for 2 minutes, and this is the question of what families need. I think as a homeless and housing service system, we have spent the last 20 to 30 years trying to figure out what families need. And I think this is quite a misnomer that we need to question. We do assessments, we decide they need this service and that service. They need that for what? To what end? To prove their mental health? Will that help them stay housed? Maybe in some cases. I can argue with a lot of data, maybe not. Maybe they'd have just the same likelihood to stay housed. So I think we have to question. We need to question our methods. We need to rethink it. Homeless families do not look the same as homeless single adults. And if we continue to work with them that way, we're going to use up a lot of precious resources we could be using for other things, like rent. You know, part of the reason we do this is because the government and other funders tell us, this is funding for this, right? This funding is for a mental health caseworker. All right, so now I have a mental health caseworker. I better figure out which families need mental health. This is a problem. You know, we may find out that our perception of normal and normal family functions is the bar may be set too high. What do the other families look like in the last housing that this family had in a poor neighborhood? Maybe our goal as a housing and homeless system is to help them look more like those families and not push it, not purposefully try to move them up the ladder, not try to solve all these other problems, but use the money for rent. Our purpose is housing. And I have this need to say this because I feel like we keep going down this road and we're chugging and we're chugging and we're building more services and more ways to provide services. And we're not really using what we know. We all know that there are families that look like the homeless families that are housed. Something happened. They became homeless. We can deal with the something that happened. Now we should see if they can go back to living where they were before. They may not be great. Their kids still may have to go to schools that aren't great. The apartments may not, be well appointed. They may not have good furniture. It just may be they're returning to that state. But where does our system and what we need to do end, and where does something else pick up? I think it's an important question. And I also think that we feel like we have to make them better. And I say better than who? And better than what? I don't want to be cruel about it. I think every child should have the opportunity to go to a good school and to do well. But we have limited resources, and I think we need to spend them on what's most important. And I believe housing is central. I believe helping someone pay their rent when they can't is one of the most important essential elements. And I'm going to end it there.